Hi, I'm Angela King, and this is my husband, Dominic McCann, my patient model, and we're here to talk to you about the Exsufflation Belt. The problem: patients who depend on long-term non-invasive ventilatory support using a mask or a mouthpiece often experience reduced ability to talk, eat, or drink, aerophagia, facial skin breakdown, disfigurement of the facial bones and teeth due to long-term use of the mask, dry mouth and throat from inadequate humidification of air and retained secretions, and reduced social engagement and public exposure. And aerophagia, by the way, means swallowing air. That causes gastric distension and discomfort for the patient. The solution to these problems is intermittent abdominal pressure ventilation, IAPV. Intermittent abdominal pressure ventilation is delivered via the exsufflation belt. The belt includes a soft fabric covering that holds an inflatable bladder, which is then connected to a positive pressure ventilator. When connected to a positive pressure ventilator, the belt delivers intermittent positive pressure to the patient's abdomen. This slide shows the exsufflation belt, the bladder in the soft belt, and the extender. The patented FDA-approved exsufflation belt consists of a sturdy fabric abdominal corset-like garment that encases an inflatable inner bladder. The bladder comes in two sizes, adult and extra small. The belt also comes in two sizes, medium waist and small waist. There is also a belt extender, seen here, that can be used to accommodate patients with a larger waist. Who is a candidate for IAPV? Patients who depend on long-term non-invasive ventilation suffering from the following diseases: amyotrophic lateral sclerosis, kyphoscoliosis, muscle mitochondrial and myofibrillar disorders, muscular dystrophies, neurodegenerative disorders that cause hypoventilation, partial and/or bilateral diaphragmatic paralysis, post-polio syndrome, pulmonary restrictive diseases, spinal cord injury, spinal muscular atrophy, and select patients with hypercapnic COPD. Who is not a candidate for IAPV? Some patients who are too thin with no abdominal mass because there's nothing to compress. Or patients weighing more than about 200 to 250 pounds because the diaphragms are already high. Or patients with altered mental status or those who cannot cooperate. This diagram illustrates how the belt works. On the left, the bladder is inflated by the patient's positive pressure ventilator. This actively elevates both diaphragms, leading to a rise in intrathoracic pressure, causing the patient to exhale. On the right, the bladder deflates passively. This causes the diaphragms to gravitationally fall, facilitating a drop in intrathoracic pressure, causing the patient to inhale. The system provides respite from continuous mask or mouthpiece use. This technique is called intermittent abdominal pressure ventilation, or IAPV. Remember, when the bladder inflates, the patient exhales. When the bladder deflates, the patient inhales. The benefits of IAPV that are not possible with mask ventilation. The exsufflation belt benefits the patient's overall health and well-being by increasing tidal volumes from 300 milliliters to 1,300 milliliters, assisting with a more normal breathing pattern, improving mucociliary action with better cough by increasing expiratory flows, inflating the lungs more fully while unloading the respiratory muscles, giving respite from full-time use of facial or oral interfaces, allowing the patient the ability to speak and eat freely, reducing the risk of mid-facial hyperplasia and dental malalignment and facial skin necrosis. Additional benefits include improving lower lung inflation, thus reducing the risk of hospitalization from respiratory complications, allowing adequate humidification of inspired air by using the patient's natural nasal airway, reducing self-consciousness, enhancing seating posture and cosmetic appearance, sustaining stable home ventilation, and providing a more normal appearance with adequate respiratory support can allow gainful employment, social interaction, and improved quality of life. A typical installation. Gather your materials: a tape measure, the bladder you'll be using, a soft belt, the extender if needed, a disposable exhalation port, and optional, a 6-inch corrugated tubing and a 1522 adapter, and an oximeter. Ideally, a CO2 monitor and a respirometer. If a respirometer is not available, a typical home ventilator capable of delivering CPAP of less than or equal to 4 centimeters with a filter, full face mask, and CPAP tubing can be used to collect volume measurements. You will also need the patient's usual ventilator and circuit to power the exsufflation belt. Prepare the patient. Explain the use, rationale, risks, and benefits for the system, and encourage the patient to ask questions. Ask the patient to empty their urinary bladder before beginning, and have the patient sitting upright in a high Fowler's position. Depending on the monitoring equipment available, measure and document the patient's baseline, unassisted, respiratory rate, tidal volumes, minute ventilation, forced vital capacity, oxygen saturation, and CO2 on ambient air, or supplemental oxygen if typically used. If using a home ventilator for monitoring, set it to the lowest possible CPAP setting and turn all the alarms off. Help the patient don a full face mask and turn the CPAP on. Let the patient relax into it a few minutes. You should be able to collect respiratory rate, tidal volumes, and minute ventilation from the vent monitor. Record the data. If you don't have any means to monitor volumes, you can have the patient count aloud on a single breath, starting from 1. Record how far they get, 1, 2, 3, 4, and so on that one breath. You will repeat this measurement when the patient is using the belt. If the patient's tidal volume is increased when wearing the belt, they will be able to count to a higher number. It's a good idea to establish baseline values. So we're going to take an oximetry reading. Get going for us. We don't have a pulmonary function machine or a right respirometer, so we're just going to use a typical home ventilator. What we've done is set it to the lowest CPAP possible which on this particular machine is 4 centimeters. And we're going to go ahead and put that on the patient with a full face mask. We'll give him a few minutes to get comfortable. But we should be able to use the ventilator monitored data to get his resting respiratory rate, exhaled tidal volume. We can get that for several of them and kind of get an idea of an average tidal volume and then even a minute ventilation. After we get our baseline oximetry data, CO2 would be wonderful if we had that monitor. And whatever monitor data we're going to get from our ventilator, our right respirometer, or our pulmonary function tests, then we'll be ready to put the belt on. Have the patient locate their anatomical markers. The upper edge of the belt will sit just below the xiphoid process. The lower edge of the belt will sit just above the pubic arch. The belt must encase the umbilicus and lower portion of the rib cage. Measure or eyeball the patient's circumference midway between the xiphoid and the umbilicus. This will help you select the proper size bladder and belt. Choose the appropriate bladder and belt for the patient. There are 2 sizes of bladder, the adult bladder and the extra small bladder. And there are 2 sizes of belt, the adult belt and the extra small belt. There is also an optional belt extender, which can be used to lengthen the adult belt. Usually, when using a large bladder, the adult belt is used, but not always. There may be some situations where the large bladder is used with the small belt. Prepare the exsufflation belt. Insert the bladder into the belt. The coupling where the tubing will be connected can be positioned on the left or the right of the exsufflation belt. The belt can be used with a coupling in the up or down position. Remember, the bladder goes in the front against the patient's umbilicus. Determine the type of ventilator circuit or tubing currently being used, if applicable. Does the patient use a positive pressure ventilator now? If so, it is usually best to use the same circuit and tubing so the patient can easily switch between belt, mask, and/or mouthpiece therapies. If the patient wants to use the same circuit or tubing, it's important to understand the type of circuit and tubing the patient is using. Is it an active circuit, a passive circuit, or simple CPAP tubing? If the patient does not have a ventilator currently, use CPAP tubing with a disposable exhalation port with the exsufflation belt. This is the easiest, least costly, and most durable. Types of ventilator circuits and tubing. All the different types of ventilators and ventilator circuits are compatible with the exsufflation belt. The important thing is to make sure that there is a way for the air to leave the bladder between breaths. On the left, we see an active circuit. An active circuit has a valve controlled by the ventilator that opens and closes to allow the air to be flushed out. This circuit will work perfectly with the exsufflation belt. No adapter is needed. In the middle is a passive circuit. A passive circuit has holes at the end of the tubing for the air to be flushed out. A passive circuit will work perfectly with the exsufflation belt. No adapter is needed. On the right is plain CPAP tubing. CPAP tubing does not have an exhalation valve or any exhaust holes because the tubing is usually connected to a mask that has exhaust holes. CPAP tubing works well with the exsufflation belt because it is durable and very inexpensive, but there's no place for the air to escape between breaths. If using CPAP tubing, add a disposable exhalation port to the bladder coupling. CPAP tubing can work with the belt. We just need to add a place for the air to escape between breaths. If using CPAP tubing, add an exhalation port between the belt coupling and the CPAP tubing. There are many exhalation ports available. This particular one works very well and is durable. There is a small hole on the side of the exhalation port for the air to exhaust. Once you start using the belt, if the ventilator alarms due to insufficient exhaust, the white cap can also be opened to allow for additional air to exhaust. Set the ventilator that will power the belt. We call the ventilator that powers the exsufflation belt the belt vent. The belt vent will probably have an option to select the circuit type: active circuit, passive circuit, or mouthpiece valveless circuit. Depending on the ventilator manufacturer, CPAP tubing may be called a valveless circuit or a mouthpiece circuit. If available, set the belt vent to mouthpiece mode. This will eliminate PEEP or EPAP, which are not needed when using the exsufflation belt. Set the belt vent sensitivity to off or as unsensitive as possible. The patient does not trigger breaths when using the belt. They ride the vent. Set the mode to assist control pressure or PAC. Start with a pressure control setting of 15 to 20 centimeters. If the belt vent has a rise time, set it to the fastest airflow to fill the bladder quickly. Set the breath rate to a comfortable rate for the patient. This rate will probably be slightly less than the patient's unassisted breath rate. Turn off all the alarms except the high pressure alarm set at 45 centimeters. Note, many vents will not have a high pressure alarm available in the pressure mode. Turning off all the alarms except for the high pressure alarm will help reduce distraction and annoyance during the titration process. Set the inspiratory time. Calculate the breath cycle time. 60 seconds divided by the set breath rate equals the cycle time. Be aware, the belt vent's inspiratory time setting is actually the patient's expiratory time when using the exsufflation belt. The patient exhales when the belt inflates. Use the cycle time minus the set inspiratory time to calculate the patient's actual inspiratory time. For example, with a breath rate of 15, the ventilator set inspiratory time of 2.5 seconds. 60 divided by 15 gives a 4-second cycle time. A 4-second cycle time minus the set inspiratory time of 2.5 seconds gives 1.5 seconds actual patient inspiratory time and 2.5 seconds actual patient expiratory time. Let's look at another example. Breath rate 20. What is the cycle time? 60 divided by 20 is 3 seconds. If you set the belt vent's inspiratory time to 2 seconds, what is the patient's actual inspiratory time? A 3-second cycle time minus the set inspiratory time of 2 seconds equals a 1-second actual patient inspiratory time and 2 seconds actual patient expiratory time. Remember, the belt vent's inspiratory time setting is actually the patient's expiratory time when using the exsufflation belt. The patient exhales when the belt inflates. Put the exsufflation belt on the patient. The belt vent should be powered off while you place the belt on the patient. The bladder goes in the front. The belt should be adjusted to fit snugly at the end of a forced exhalation, but not so tight as to be uncomfortable. You should be able to insert 2 fingers under the belt when it is not inflated. If using CPAP tubing, make sure there is an exhalation port connected to the bladder coupling. Connect one end of the circuit tubing to the belt vent output and the other end to the belt coupling, or the exhalation port if used. Now we're going to put the exsufflation belt on our patient. I measured him earlier today and he was about 33 inches, right on the cusp. So we're going to try, this is the adult bladder and the medium belt. We may need to use the belt extender, but we'll try it without it first and see how we do. Now notice we're going to put the belt over this lightweight shirt. That would minimize any irritation to his skin. Now we've tried this previously and he preferred the outlet facing down on him. Now you can wear it either way. We can have the outlet on either side and it can be at the top or the bottom, either way. But we have to have the bladder in the front across the patient's abdomen. So we've already practiced it and he wanted it in this position. Okay, so we're gonna have him lean forward and find that xiphoid process. We're going to be underneath the xiphoid process. We're going to fully encase the umbilicus, his belly button, and be above the pubic arch. We're going to have him forcefully, oops, I don't think I have it quite straight. I think I'm twisted. There we go. We're going to have him forcefully and fully exhale, and then I'll push it together, pull it together. Go ahead. Exhale, exhale, exhale. Good. And I made it without the extender. So we'll see how that does. Now, I've got the outlet right here. When we tried it earlier, he preferred me to add just a little bit of blue corrugated tubing to move the air outlet a little bit away from his body. So we're just going to attach that easily. And then we can attach our ventilator tubing. Are you ready? Mm-hmm. And we'll start the ventilator. Now this is snug, but probably not snug enough. Look how easily I can get my fingers in there. Do you think I could snug it up some more? I generally start somewhere between 15 and 20. I started him at 17, but we can easily increase that. So I'm going to do that right now. We'll go up to 19. Now, for the therapists that haven't worked with the exsufflation belt before, takes a little getting used to. Remember, when the bladder is inflating, the patient is exhaling. So it takes a little while for him to get in sync. We'll let him just relax with it for a few minutes, and then we'll come back and measure our volumes again. Now, as you can see, we've given him some time to adjust and relax. And we can see lovely volumes. We definitely have a volume improvement. He's comfortable. His saturation looks great. His heart rate looks good. And he's relaxed. Turn on the ventilator that powers the belt. It will take a few minutes for the patient to get in sync. You may ask the patient to say now, now, now when they feel the bladder pushing on their abdomen. It may help the patient to watch the pressure bar graph on the ventilator that powers the belt. As the pressure bar increases, the bladder is inflating. The patient should be deflating or exhaling. As the pressure bar decreases, the bladder is deflating. The patient should be inflating or inhaling. Increasing the pressure control setting increases the patient's tidal volume by increasing the motion of the diaphragm. Give the patient some time to adjust and get comfortable. Gather data. Record the patient's saturation and CO2, if available. If using, help the patient don the full face mask again and turn on the monitoring vent. Observe and record the monitoring vent's data display. When finished, turn off the monitoring vent and remove the full face mask. If you had the patient count, have the patient count aloud again, as high as they can on a single breath, and record the number. Additional tips. Once the patient is comfortable, it is a good idea to have the patient move to a semi-recumbent position and measure any changes in ventilatory parameters. The patient may need prescribed ventilator settings for the upright position and the semi-recumbent position. Make a written plan for which circuit the patient is to use with which ventilator program and mode, mask, mouthpiece, and belt. Ideally, the patient or family can keep a journal recording hours of use per day, whether sleep is refreshed, any changes in appetite or eating, and any other relevant information. One of the benefits of the exsufflation belt is that patients can eat with the belt on, swallowing at the end of exhalation and before the next inspiration, as we normally pause our breathing to swallow. Respiratory satiety is the goal. Respiratory satiety is achieved when the patient has dyspnea relief, often evidenced when the patient smiles or falls asleep. Absence of dyspnea is the goal, as opposed to achieving a certain pressure. Thank you for joining us to learn about the exsufflation belt. Please feel free to contact us for more information.